Oh, right. So let's get started here. So thanks, Dr. Mari, for passing things over to me here. For those of you that don't know me, actually, I'm Karina Kowalik. I'm an assistant professor in Winnipeg, Manitoba at the University of Manitoba. And so today we have three speakers. The first off is going to be Dr. Marrodan, who's going to be talking about therapeutic plasma exchange in MS and some of the long-term outcomes. So I'm really looking forward to this. So please go ahead, Dr. Marrodan.
Okay. Well, good morning, everyone. My name is Mariano Marrodan. I'm a neuroimmunology fellow at FLENI in Buenos Aires, Argentina. Before I begin, I would like to say that it's an honor to have been asked to give a presentation today, and I would like to thank the organizers for extending me the invitation. I have no conflicts of interest related to this presentation. And as we all know, MS is a chronic inflammatory disease of the CNS leading to demyelination and neurodegeneration. Up to 85% of MS patients present a relapsing intermediate course. And in patients presenting this phenotype, different authors have demonstrated that residual disability may persist after relapses, as can be observed in this interesting research conducted by Dr. Ludling and colleagues. More recently, another group of researchers reviewing allocation effects of MS therapies observed that after high dose of IV methylprednisolone, up to 25% of patients will still present residual disability after relapses. This can also be observed in this schematic illustration, showing how not all patients present complete recovery, and some of them experience accumulated disability with further relapses. In an attempt to reduce relapse-associated disability, therapeutic plasma exchange, or TPE, has been used for some time now, mostly after IV methylprednisolone pulses. This paper by Dr. Wilshire et al., published in 1999, was one of the first to address this topic and demonstrated clinical improvement in over 40% of patients with CNS demyelination after TPE. A few years later, a large case series was published in Neurology on patients with neuroimmunologic disorders, showing favorable outcomes after early TPE, especially in males with ESS scores under 8 and absence of deep tendon reflexes. However, if we take a detailed look, this large case series included several types of CNS demyelinating disorders, probably mediated by different underlying pathophysiological mechanisms. Therefore, these results need to be interpreted with caution. In an attempt to resolve these discrepancies, Dr. Krebs and colleagues evaluated a group of MS patients and described favorable clinical outcomes in most of them after TPE treatment, in some cases lasting as long as 42 days after treatment. In another case series, including over 40 patients with demyelinating disorders followed for 6 months, relapsing-remitting patients showed clinical improvement after TPE. It's interesting to mention that this case series remains, to date, the registry with the longest follow-up. A recent article compared with a patient with steroid-refractory MS relapses treated or not with TPE. Patients presenting significant clinical improvement in clinical deficits lasting up to 3 months after treatment with TPE are shown here in green. In yellow are shown patients with partial recovery, and in red those with no improvement.
Yes, you know, I just realized as you're calling,
Sorry? Okay. Given these considerations, the fact that most case series included different demyelinating or autoimmune disorders, and that even those studies on MS alone only followed patients for 6 months or less, we decided to assess long-term clinical response to TPE in steroid-refractory MS relapses. As a secondary objective, we also want to contribute knowledge on MS treatment results from a regional-based perspective. After reviewing medical records of patients attending FLENI's MS clinic from 2011 to 2018, we identified 562 patients with relapses. Patients who received IV methylprednisolone and TPE were selected, and those cases with secondary progressive MS were excluded to avoid results misinterpretation. The control group included patients with steroid refractory MS relapses not treated with TPE, matched by sex, age, and EDSS score at time of relapse. All patients were followed up for at least 24 months. Modified ranking scale and EDSS scores were used to evaluate disability. Significant response to treatment was defined as decrease or improvement by at least 0.5 or 1 point in EDSS score from the moment of the relapse. Our results are summarized here. No significant differences were observed between patients treated with or without TPE regarding sex, age, cardiovascular risk factors, disease-modifying therapy, presence of gadolinium-enhancing lesions, and grams of methylprednisolone received, or number of prior relapses. The only difference we found was that patients with refractory MS relapses not receiving TPE presented on average longer duration of disease at the moment of the relapse. No significant difference were found regarding type of disease-modifying therapy and at time of relapse or affected FSS between groups. At this point, we want to compare our response rate with TPE to those compared with most relevant published cohort to date. As shown in this table, our rate was 78%, in line or slightly above previously reported series. We must mention once again that each study applied different patient selection strategies, and we only included relapsing remitting MS cases with steroid refractory relapses. We compared median EDSS scores in both groups at time of relapse at first, third, and 6 months, as well as at 1 and 2 years after MS exacerbation. Interestingly, we found statistically significant differences between both groups at 6 months and at 2 years follow-up. Absence of statistical significance at 12 months may have been the result of missing data at this time point, ultimately reducing the study sample size. Similar results were found on MRS evaluation. TPE patients presented lower MRS scores than patients not treated with TPE at 6 and 24-month follow-up. Adverse effects were found in up to 43% of patients receiving TPE, but not life-threatening events occurred. In conclusion, we can say that TPE is an effective treatment for steroid-refractory MS relapses and 78% of response rate in our cohort. Patients treated with TPE also presented lower EDSS scores at 6 and 24 months compared to patients not receiving TPE. And we think that these results contribute novel information on long-term outcomes in relapsing remitting patients treated with TPE, as well as region-based information on MS, which is scarce. Regarding further perspectives, we're now conducting an extended follow-up study on this patient's cohort. We are also planning a multi-center prospective study on TPE in MS relapses, as well as a research project with similar design in NMOSD patients. Finally, I would like to thank the Neuroimmunology Department of FLENI, and particularly to Dr. Scorreale and Dr. Cifrelit for mentoring me during this project. And thank you all of you for your kind attention.
Great, thank you so much, Dr. Marrodan. I've got a question, but I can open it up to everyone first in case anyone else wants to go first and ask any questions. You just have to unmute, I guess, yourself if you want to ask a question. Okay, there's no one grabbing the mic right now, so I can go ahead. Dr. Marrodan, in one of the original or the initial slides, you had showed a significant difference between the disease duration between the two different groups. Do you think that that has any, or I guess, what is the role, I guess, of the different disease durations in the two groups, or is there a role, do you think, in your mind?
I think that it's related with the time when patients presented that the relapse. TPE is used frequently nowadays, but some years ago it was not so frequent. So those patients were from previous records than patients treated with TPE. I think that this can be explained in this sense.
I see. Okay, thank you.
I have a question. With that in mind, so you're saying the TPE patients are more contemporary, they're more recent years. Did those individuals also tend to start on stronger disease-modifying therapy in the course of follow-up compared to those who didn't receive TPE? And could that account for the differences in EDSS in the long-term follow-up?
Okay. Yeah, we reviewed this topic specifically, and we found that we didn't find differences between drugs selected after MS relapse in different cohorts, because those patients were not so well. So all of the patients were selected from 2011 to this time. So most of them were very well to high drug efficacy drugs.
Oh, I see. Mm-hmm. Okay. And did you have any data about like when in the time course of the relapse they were treated, like how many days in?
We revised this topic too, and we didn't find differences in response to TPE according to the time that the treatment was used.
Thank you.
You're welcome.
Thank you, Dr. Marrodan. This is Maria. I'm also a clinical fellow. So thank you for the talk. I'm just like curious. So I'm Colombian, but I'm currently finishing my training here in the US. So being Colombian, of course, I'm a little bit like interested in the logistics of like studying the plaques in this group of people. Like usually, how do you run that? That's just like so interesting for me to listen to, because I know that sometimes we do have challenges with that. So it's more about the logistics. Thank you.
Okay, thank you. Here in FLENI, we are in a tertiary neurological center. So when we need to do TPE, patients are hospitalized at least for the first and second TPE session. And if patient is available to walk and be at home, they came to the I don't know how to say it, to the hospital to do TPE, and they come back home for at least 5 sessions.
I guess another question I had in regards to logistics, like do you actually, like when you classify the patients as having like a refractory relapse, usually like how many days are you taking into account, or like have you do this like in a standardized fashion, like let's say about like the first 5 days of methylprednisolone, if like there's no improvement, or do you still wait for a couple of weeks before like actually starting the second line treatment?
Actually, definitions are a little bit controversial at this point. For this patient selection, we decided to wait at least for 3 weeks after MS relapse, but actually I can say specifically which time you should select to say that it's an MS steroid refractory relapse.
Thank you.
I have a question. In the patients you treated with exchange, did you find that those who had longer time between the relapse and the exchange actually did not as well as the ones who were exchanged earlier? Like, how long did you wait? What's the longest time between a relapse and an exchange for that relapse?
Okay, well, in our cohort, patients which with the later TPE treatment had around 45 days, but in the paper shown that I showed by Dr. Krebs and colleagues, until 42 days, I think the patient showed any kind of clinical response. So I think that it's a patient-to-patient discussion, because if patient has a severe clinical deficit, I think that around 1 month and 40 days it would be reasonable.
So for your series, you don't see a difference between those treated within 2 or 3 weeks of relapse and those treated later, right?
No. But I have to say that it's a small cohort.
Yeah.
23 patients were selected for this study, so maybe if we take a bigger cohort or a multicentric cohort, it would be, we could have probably different results.
Mm-hmm. Thank you.
You're welcome.
Thank you so much, Dr. Marrodan. And I'm sorry I didn't mention your background and where you're from. So Dr. Marrodan's a neuroimmunology fellow in Buenos Aires in Argentina, and I guess most recently started his training as a clinical and research fellow at the FLENI under the mentorship of Dr. Coriali. I'm sorry for pronouncing that correctly. And prior to that, completed his neurology residency at the same institute in 2018. So thanks very much for your presentation. Anyone that wants to reach out, please go ahead. And so we'll go on to our second presenter for today, which is Dr. Ethel Ciampi, who's an associate professor in Chile. Dr. Ciampi will be speaking about pregnancy trends in Chilean women with MS. And so just a brief bio. So Dr. Ciampi received her medical degree from in Chile in neurology at the same university, and so she was actually awarded an ECTRIMS clinical training fellowship at SEMCAT, which is in Barcelona, during 2013 to 2014, and then returned to the PUC, where she is currently an associate professor. So thanks very much for joining us, Dr. Ciampi. So whenever you're ready, you can go ahead and start your presentation.
Thank you so much for the presentation. I will share my screen right now. There. Thank you for inviting me to present this project. It's about pregnancy in Chilean women with MS. A few words about our country. We have a very long country, so we have some accessibility issues for all patients, not only with MS. We have a low to medium prevalence of the disease. Only relapsing remitting MS patients have insurance coverage for diagnosis and treatment. This is since 2010. And just from July 1st in 2019, patients with primary progressive MS are able to receive ocrelizumab. Nonetheless, our patients appear similar to North American and European cohorts. Right now, we are working as a two-center MS unit. We have the private clinic from the university hospital, and we also have a public hospital. Together, we have about 800 patients in regular care. We have these 5 topics of research. We have some studies in comorbidities and epilepsy. We also have some real-world data and patient-related outcomes studied with the engineer laboratory clinic with MRI, some studies with cognitive impairment and social cognition, and this study that I will present you about pregnancy and other studies with MS and gender. So we all know that women represent 2/3 of the MS population and are usually diagnosed during the childbearing age. And family planning is a major life event for any woman with MS, mainly because of the risk of future physical and cognitive disability and the social burden imposed for their partner and their children. Also, it is a very challenging issue for us as neurologists when prescribing their DMT. Since 2010, as a group, we've recommended patients in childbearing age only to discontinue lateral acetate or interferon after confirmed pregnancy. This was because of avoiding any washout periods or a risk of disease activity while they desire to become pregnant. And also, we recommend exclusive breastfeeding as in all women. Of course, there was a gap in information. There were no data about Chilean MS patients. So part of the Dr. Soler Fellowship Research Project, she developed these two sub-studies about pregnancy MS, and these were recently published in multiple sclerosis and related disorders, so I will give you these results. Our main objective was to explore the trends in pregnancy decision-making and pregnancy outcomes before and after MS diagnosis. For pregnancy information, this was retrospective, and all the MS data was collected from a prospective database. This was a summary of the telephone survey that formed with each woman. We performed descriptive univariate analysis according to the distribution and binary logistic regression for assessing the risk of cesarean section. From a total of 663 patients collected from 2008 to 2018, we identified the 3 were under regular control and have assigned informed consent, and 2018 accepted to participate. From these, 67 women had no pregnancies, and we included a total of 299 pregnancies from 151 women. 223 pregnancies were for women before MS diagnosis, and 76 pregnancies were in women after their MS diagnosis that were exposed to DMT during their pregnancy, with 48 pregnancies exposed and 28 pregnancies not exposed. When assessing the responding and non-responding cohort, we only observed a difference in disease duration. And when we evaluated those patients that responded to the questionnaire but did not have any pregnancies, they were younger. Patients that had their first pregnancy before MS diagnosis had a later MS diagnosis, 40 years compared to 28 years in the post-MS. And they also had their first children. They also have more children when they were pregnant before MS diagnosis. There were no other significant difference, but with a trend on higher EDSS and a higher proportion of progressive MS patients in the pre-MS group, but this is because they are older. About the pregnancy outcomes, we observed that post-MS women had more C-sections, 65% compared to pre-MS women, and it was adjusted for age at pregnancy. Although there was no significant difference in the percentage of emergency C-sections, so this was probably about consideration with the obstetrician. When assessing the risk for C-section in each group, age at pregnancy was associated with a higher probability of C-section in the pre-MS woman, but not in the post-MS woman. And in the post-MS group, disease duration at pregnancy was associated with a higher probability of C-section, adjusted for age at pregnancy and treatment. Unfortunately, we did not have a concomitant EDSS to be included in the multivariable analysis. We didn't observe any statistical significance between newborn or spontaneous abortion rate, gestational age, birth weight, birth height, or major malformations between women that became pregnant before or after MS diagnosis. And we also observed a similar rate of complications during pregnancy in both groups. From the post-MS patients, 63% were exposed to any disease-modifying therapy, and all patients discontinued their DMT by the time of pregnancy diagnosis. We did not observe any significant difference in pregnancy outcomes, but of course, this is a very small sample size. about relapses during pregnancy or after a pregnancy, more women reported having suspected relapse during pregnancy or up to 6 months in the post-MS group. None of the post-MS patients who reported suspected relapse during pregnancy were receiving DMT before they became pregnant. And from the post-MS patients that reported suspected relapse up to 6 months after birth, all of them were breastfeeding during their relapse and not receiving DMT by the time of the relapse. And we also observed that fewer post-MS patients reported breastfeeding. So we observed a mean number of children per woman lower than general population. These have been observed in other cohorts, international cohorts. And we also observed a post-MS delay pregnancy. This has also been observed compared with patients without MS. Although we went to see the generational fertility trends of our country, and we observed that in the pre-MS cohort, the fertility rate was 2.17 children per woman in the mean age that they become pregnant, compared to 1.7. So this is very similar to children without MS. And also we have a difference in the socioeconomical status, where a higher socioeconomical status are have a trend to delay their pregnancy. These are the women included in this study were all from a private hospital, so they are in the higher socioeconomical status. We also observed that pre-MS patients were diagnosed later than post-MS. This was also significant for age observed in 2 recent studies where childbirth could be a protective factor. Also, maybe it is related to the new diagnostic criteria. We do not know that for certain. And what was very reassuring is that the rate of spontaneous abortion is similar to general population, and the anthropometrics and malformations are similar to regional data. We also, I need to highlight this because it is a very, very high country. Women without MS have a 48% of cesarean section, but our MS women have a 66%. This is, we think, it's too much for them. We also observed the increased risk of relapse, but we think this is a combination of recall bias. We do not have the previous disease activity of this group, or maybe an influence of breastfeeding in this group. Of course, we have limitations. We have a small sample size. This is a single center study. It's a retrospective assessment of pregnancy-related information, and we did not have reliable information about the duration of the DMT exposure before pregnancy, this is activity before pregnancy, or EDSS before or during pregnancy. So we can conclude that changes in pregnancy decision-making after MS diagnosis in Chilean patients occur, having fewer children at an older age and with a lower rate of breastfeeding. But although this finding could be associated with local and generational trends, an almost threefold increase in cesarean section, not supported by increased emergency procedures, might reflect the need for more education, not only for neurologists, but also for the obstetrical team, patients, and their family. And of course, more evidence is needed in order to support our decision-making to improve the care of women with MS who are in childbearing age. Right now, we are planning to perform a study about fertility in MS with Dr. Carolina Pelayo, who is our current fellow, and we would love to work together with the IWIMS community too. Thank you.
Fantastic. Thanks very much for your presentation. That was really interesting. I guess I can lead things off and ask a couple sort of maybe more introductory types of questions, but I wonder if you could speculate why you think fewer post-MS or women that were diagnosed or are having pregnancies post-MS were reporting fewer rates or lower rates of breastfeeding.
Yes, we encourage breastfeeding, but of course there is the I don't know if it's fear of having the relapse. So many women, when they choose to start DMT, even if they haven't have any relapse, they know that they have an increased risk during postpartum, and many of them do not have breastfeeding and start DMT. So this is a discussion that we have during the first month after birth, usually. We think it's fear, but we do not have any data. That's a feeling. Yeah.
Yeah, right. Gotcha, thank you. And just one other sort of follow-up question, the higher risk or higher odds of C-section. I guess you sort of alluded to this in your last slide there, but that it could, be just, have to sort of educate, I guess, the obstetrical teams that are working with these patients. But do you think, is that a trend that's been seen sort of, in the past in other countries, or, even currently in other countries, or is that?
Yeah, our country is one of the highest cesarean section for every woman, not only with MS, but of course, an elective cesarean section has some risks. So what we are doing right now, and for the past, I don't know, about 5 years, we have a neurology appointment about 30 weeks of pregnancy, and we have a medical report for the obstetrician to tell them that it is safe for the women, if the pregnancy allows it, to have a vaginal delivery, and there is no contraindication for all the anesthesia, so that is always a concern with the patient. But it was interesting to have this this data that maybe disease duration was related to a slightly higher increase in the cesarean section, and we would love to include the current EDSS in this evaluation, because we do not know if these women had higher EDSS. That's a missing data. Yeah.
That's interesting, thank you. Does anybody else have any other questions? Okay, I will, if anyone has any other questions, feel free, of course, to contact Dr. Ciampi directly. So then we will move on to our third speaker for today, which is, let's scroll down here. Well, there she is right there. Dr. Huah Ning, who is currently a postdoc fellow at the University of British Columbia. And so Dr. Ning has completed her Bachelor of Pharmacy PhD at the University of South Australia in Australia, and also has experience as being a pharmacist, working in both hospital and community settings, and currently is conducting a series of observational studies using linked administrative health data in BC or British Columbia to look at some of the long-term benefits and adverse effects related to disease-modifying drugs for MS. And so at UBC, Dr. Ning is part of Dr. Helen Tremlett's group. And so I'm looking forward to hearing from you, Dr. Ning. Please go ahead.
Hi, good morning or afternoon, everyone. Today, I'm going to present to you one of our research paper published last year entitled Adherent to Laboratory Monitoring Among People Taking Oral Drugs for MS, a Canadian population-based study. This is my disclosure. The study was funded by the MS Society of Canada. I do not have any potential conflict of interest, commercial conflict of interest associated with this study. I've received funding for my postdoc research training from the MS Society of Canada, Michael Smith Foundation for Health Research, and the Canadian Institutes of Health Research. Throughout this presentation, I will be using the acronym DMT to represent disease-modifying therapy. The oral DMT for MS, such as dimethyl fumarate, fingolimod, or teriflunomide, are associated with improved drug adherence relative to injectable DMT, such as beta-interferon or glatiramer acetate. However, there is very little information on adherence to the recommended blood and urine monitoring tests in the MS population. The objective of this study was to examine adherence to laboratory testing by person initiating an oral DMT for MS. We conducted the cohort study using linked administrative health data and laboratory data in the province of British Columbia. British Columbia is the westernmost province in Canada, as shown in the map below. The data capture about 4.7 million of all the residents in British Columbia, and this represents about 13% of all the Canadian population. The linked data that we have access to for this study comprise 6 different data sets as listed in here. Prescription data provided information on all the medication dispensed in the outpatient or community pharmacy, including the use of MS-DMT. Hospital and physician data capture medical diagnoses that were used to determine comorbidity of the study population. Vital statistics capture death records. Universal Healthcare Registry provided information on residency status and demographics. And lastly, laboratory monitoring data capture about 99% of laboratory tests in British Columbia. We identify all individuals in British Columbia who received their first prescription for an oral DMT between 2011 and 2015. This data ensures capture of all people with MS who were newly exposed to an oral DMT. The oral DMT included in our study were fingolimod that was first approved for use in Canada in 2011, followed by dimethyl fumarate and teriflunomide approved in 2013. 2 other oral DMT, including siponimod and cladribine, were not included in our study as they were approved after 2015. The study population will follow from their index date, which was the first dispensation date of the oral DMT until the earliest of death, immigration from the province, discontinuation of the oral DMT, or up to 31st December 2015 as the study end date. We measure the proportion of people adherent to the recommended laboratory monitoring requirement, including lymphocyte count, liver enzyme level, and urine protein, based on the relevant product monograph approved by Health Canada. And this is equivalent to the prescribing information approved by the FDA in the United States. Adherence was defined as evidence of at least one test performed within a specific time interval. Pre-treatment included the entire 6-month period before the first oral DMT exposure. On treatment included the first 6 to 12 months during DMT exposure and was assessed using the following time interval: 6 monthly for dimethyl fumarate, 3 monthly for fingolimod, monthly for 6 months for teriflunomide, and this time interval was based on the recommendation from the Canadian product monograph. A 20% grace period was allowed as used in drug adherence study. For example, adherence to a 6-month pre-treatment test was defined as evidence of the relevant test within this 6-month period plus a 20% of the time window, which is an extra 1.2 months through to the index date, as shown in this figure for the period highlighted in red. Similarly, adherence to a 6-month on-treatment period was defined as evidence of the relevant test within this 6-month period, plus a 20% of this time period. Data on the following patient characteristics were extracted: sex, age, socioeconomic status, comorbidity burden measured using the Charlson Comorbidity Index, based on the medical diagnosis captured from the physician and hospital data during the 1-year period before initiation of the first oral DMT. Exposure to non-oral DMT during that 1 year period was also captured. We then assessed whether the above listed patient characteristics were associated with adherence to the pre-treatment test by using multivariable logistic regression model and adherent to the on-treatment test by using logistic regression model fitted via the generalized estimating equation to allow analysis for repeated measurement. This table shows the overview of the cohort characteristic. A total of 1,016 people with MS who initiated their first oral DMT between 2011 and 2015 were included in our analysis. Most of our study population were women, as expected, as MS is more common in women than in men. The mean age at first oral DMT was about 43 years. Comorbidity burden was low, with about 90% of our study population reported no comorbidity measured using the Charlson Comorbidity Index that includes 16 different chronic conditions captured during the 1 year period prior to the initiation of their first DMT. Dimethyl was the most commonly dispensed oral DMT, followed by fingolimod and teriflunomide. Over half of the study population had prior exposure to a non-oral DMT and typically a beta interferon during the 1 year period before initiation of their first oral DMT. These three figures show the proportion of people adherent to the recommended laboratory tests in the months before and after starting their oral DMT. The figure on the top left shows the result for dimethyl fumarate, the top right for fingolimod, and the figure on the bottom for teriflunomide. In each of these figures, x-axis represents time period and y-axis represents proportion of people with a test. Black bars show the result for biochemical liver tests, blue bar for lymphocyte count, and yellow bar for urinalysis. You may notice that urinalysis is only required for dimethyl fumarate and not for the other two oral DMT. I will now focus on the results captured during the pre-treatment period, as highlighted in the red box. Adherence to the pre-treatment test was particularly high across all tests and for all the three oral DMT. Over 90% of our study population completed a lymphocyte count as represented by the blue bar before initiation of each of these oral DMT, and over 88% adhere to the monitoring of liver tests as represented by the black bar. 77% adhere to urinalysis before starting dimethyl fumarate. Now I'll move on to the results, focusing on treatment period. And I will be focusing on the first on-DMT liver test as represented by the black bar captured in the red box. Adherence to the liver test vary across the three oral DMT, ranging from 40% for teriflunomide to 89% for dimethyl fumarate. The lower level of adherence for those taking teriflunomide could be explained by a higher testing frequency required for teriflunomide. For example, a liver test is required on a monthly interval, whereas for dimethyl fumarate on the 6-month interval, and for fingolimod, a 3-month interval. We then assess whether sex was associated with adherence to the recommended monitoring, and the results are shown in this table. The orange column shows the result during pre-treatment period, and the green column shows the result for on-treatment period. An odd ratio above 1 indicates a higher likelihood of adhering, and an odd ratio below 1 indicates a lower likelihood of adhering to the recommended test. We observe sex differences in relation to adherence to the recommended test. Men were less likely than women to adhere to several recommended tests with dimethyl fumarate, as highlighted in the red box. For example, men were less likely than women to have completed an urinalysis before starting dimethyl fumarate. Men were also less likely than women to have completed a biochemical liver test or a lymphocyte count while taking dimethyl fumarate. We also assessed whether pre-exposure to another DMT was associated with adherent, and the results are shown in this table. Similar to the previous table, the orange column shows the result for pre-treatment period and the green column for on-treatment period. We observed that people with previous exposure to a non-oral DMT in the 1-year period before starting their first oral DMT were more likely to be monitored for pre-treatment liver and lymphocyte count, but the results were non-significant during on-treatment period. All other patient characteristics, including age, socioeconomic status, and comorbidity burden measured using the Charlson Comorbidity Index, were not significantly associated with adherence to laboratory testing pre-treatment or on-treatment. Moving on to discussion, the reason why men were less likely than women to adhere to the routine dimethyl fumarate-related laboratory test is unclear. Factors that might explain such sex-related differences and long-term consequences of them remain to be explored. People with pre-exposure to another DMT before initiation of their first oral DMT were more likely to be monitored for a pre-treatment liver and lymphocyte test. This may be due to the other routine laboratory monitoring required for most DMT, and that people who are already on a DMT were interacting with the health system more frequently and hence were monitored more closely prior to switching to oral DMT. In summary, we found in our study that adherence to recommended laboratory tests was high before oral DMT initiation, but the proportion of people who adhere to the recommended test decreased after initiation of the oral DMT. Our findings highlight the need to understand the long-term consequences of suboptimal laboratory monitoring among the DMT-treated MS population. The sex differences also warrant further consideration. Before I end my presentation, I'd like to acknowledge the funding body of my postdoc research fellowship and the data provider for providing data access used in this study. I'll finish off my presentation by sharing with you a few other studies that I have completed in the past year as part of my postdoc research project, focusing on safety and effectiveness of DMT. Within my research group, I have conducted 2 systematic reviews to assess the safety profile of 2 DMT, including ocrelizumab and dimethyl fumarate. I've also conducted 2 other studies to describe the patient characteristic exposed to DMT in the real-world setting, as we could not fully understand the effectiveness and safety profile of a DMT without considering patient characteristics. The findings of these 4 studies have been published, and I'm happy to share a copy if interested. This is the end of my presentation. Thank you for listening.
Great, thanks very much. That was a really great presentation. I'll open up the floor to anyone who wants to ask any questions.
Thanks so much. That was a really great talk. You know, you're saying the adherence is low, and I'm like, oh, that looks pretty good, actually. It's a lot better than my patient population. Do you have a way of understanding, like, and maybe you said this and I missed it, but whether these are patients for whom the labs are ordered and they simply aren't going, or if it's a miss on the part of the providers who are accidentally kind of under ordering laboratory assessments?
Yeah, we actually can't differentiate with, we can't tell whether patient have completed a test, because I think the laboratory data capture whatever the doctor ordered, regardless of whether patient attended the appointment. So, and yeah, so, yeah.
So you can't distinguish if it was ordered but not done compared to ordered. Okay. So it could be that it's even lower adherence to getting the labs done. You're just looking at like the doctor side of it.
No, Shin, can I jump in?
Yeah,
Very cheeky.
certainly, yes.
Sorry, Helen here. So no, the lab tests that we were picking up there were tests that were actually completed.
Done.
So we can't tell. I think it's a brilliant question. I'd love to know what was actually written by the physician for the patient to do, but what we accessed was tests that were actually done.
Okay, yeah. Because at least in my clinic, when I go to order the routine follow-ups, often it says, you've already ordered this test like 5 times and it's not done, you know? So I just wonder from a QI perspective, and, you know, are the patients not getting the test done despite having them ordered, or is there some kind of improvement in clinical workflow?
But I think it's a great question what you ask. I'd love to know what the gap is between what the physician actually ordered and what the patient actually did. But this is what was actually done, the test actually done and completed.
Got it. Thanks.
Thank you, Helen.
I just have a quick clarifying question. I guess you can state if I'm incorrect, but I always thought that when I was looking at sort of a similar type of issue with the beta interferons from many years ago, that I thought that a patient couldn't get another prescription or couldn't get a prescription refill unless they'd done their blood work. Is that sort of, I mean, I don't know much about the, how it works, when they have to go in for follow-up to see the neurologist and things like that. I guess it's on a yearly basis after it's, after they've been on it for long enough. But can you, do you know how it works with some of these oral medications? Like, can they not get another prescription until they've done their blood work? Or does it not always work out that way when, with the timing of blood work and prescriptions?
I'm not sure if that is a mandatory requirement to have a lab test done before they get their next prescription filled. So I'm not sure.
Gotcha.
Yeah. So what is the procedure?
Yeah.
It's a really good question. I know here, like sometimes I try to hold it, but then some of those medications, if you stop the medication suddenly, the patient's also at risk of like a disease. So sometimes just, at least for me, I'm emailing them saying like, this is the last one, you really have to go. But then, it slides again. It's difficult.
It's at the discretion of the treating neurologist. So it's not black and white. There's no rule to say they can't fill the next prescription until they've not completed. It's at the discretion of the prescriber.
Looks like we've got just about a minute left. So if anybody else has any questions?
Don't have a question. I want if Ethel is still on the call. There was a messaging to everyone, but to Ethel in particular from Jennifer Graves at UCD. So good. So Ethel, you saw the message. Awesome.
Make sure you credit the IWIMS Global Epidemiology Conference for any subsequent work. Just kidding. I'm totally kidding.
Okay, it looks like that's about it. Ellen, did you want to just maybe mention the date for the next presentation? If it's kind of escaping my mind.
Absolutely. We are already gearing up for our April webinar, and we have 2 speakers arranged already. We'll send out a reminder too, but we are planning on April 26th. It's 6 o'clock in the evening, New York time, so 3 o'clock on the West Coast. And this is to accommodate one of the speakers who will be talking from Australia on the 27th in the morning. So challenging always to make sure we include everybody, but we hope that you can take advantage of the talks that are posted on the IWIMS website if you aren't able to attend in person.